Good afternoon and welcome to FactDev Connect, hosted by the University of Ottawa Department of Family Medicine. We really would like to hear from you and would like to include your voice in the conversation. So ask questions, share comments, even challenge our ideas. I want to introduce our featured speaker, Dr. Simone Dahrouge, Deputy Chair of the University of Ottawa Department of Family Medicine and Research Director at the CT Lamont Primary Healthcare Research Centre. Dr. Dahrouge's main interest is in understanding how primary care can be organized to optimize the quality and equity of the care delivered. Today, she is going to share a few tips that will help you better evaluate research, articles, and guide a journal club. Welcome, Simone.
So for today's presentation, what we're doing is we're trying to develop a toolbox of resources for folks to access when they need it. So we've developed a webinar for today's presentation. So what you're going to be hearing is actually a pre-recorded webinar. I'll be here throughout and I will be answering questions at the end of it, or even if you need that webinar to stop, we can do that and answer questions. In the meantime, in preparation, to make the most out of today's webinar, if you can get access to these two resources that are shown on your screen right now, it will be helpful for you to follow. So I'm gonna wait a little bit before we get all of this started. So the top one is the tool that we're going to be using to evaluate an article. And the bottom link is to the article that we're going to be using as an example in the evaluation.
Critical appraisal is the process of systematically examining research evidence to determine whether it should be implemented into practice. This involves 3 steps, which are the same regardless of the type of study we're evaluating. First, determining the trustworthiness of the study. Is it valid? Then, understanding how the reported measures should be interpreted, and finally deciding whether the conclusions should influence our decision making. So let's work through an example. You want to know the best way to reduce the risk of developing diabetes in patients who are at high risk. What do? So you find this article that compares metformin or lifestyle changes to placebo in reducing the risk of developing diabetes. Should you be following its recommendations? Let's start by assessing the study validity. To assess the study validity, we consider 3 aspects: the population, the follow-up, and the outcome. Okay, the population. The first question we ask is whether the patients were randomly assigned to the treatment arm. Clinical outcomes can be influenced by other factors than the treatment arm, including the underlying severity of the illness, the presence of comorbid conditions, and other known and unknown prognostic factors. Only randomization ensures that both known and unknown determinants of outcomes are equally distributed between the study arms. In the example we have, patients were indeed randomly assigned to one of the 3 treatment arms, so that's good. Second, we ask whether the random allocation was concealed. This can be achieved by having the treatment arm allocation in a concealed envelope, or more commonly done by calling a central number to get the patient assignment. This way, there's no opportunity to influence arm attribution. This article didn't provide information on whether the random assignment was concealed, so this raises the possibility that bias could have been introduced. Third, we ask whether the participants were blinded as to the treatment arm they were receiving. Often this is very difficult, especially if the intervention has a behavioral component. What about the evaluators? Knowing the treatment arm may influence the evaluator's assessment of the outcome, especially if there's room for subjective interpretation. Studies in which both the patients and evaluators are blinded as to the treatment arm are called double-blinded studies. In this study, assignment to metformin and placebo were double-blinded, meaning that neither the patient nor the provider knew what pill the patient was receiving. Of course, patients assigned to the lifestyle intervention could not be blinded, neither could their assessor. So there was a reasonable attempt at blinding the study. Finally, we ask whether the patients in the treatment arms were similar. We look for differences, especially in prognostic factors. If the treatment groups are similar at baseline, that's great. If they're not, the authors should be using statistical techniques to adjust the study results for these differences. In this study, baseline characteristics, including all measured risk factors for diabetes, were similar across the three groups. That's displayed in Table 1. Don't look for p-values to demonstrate that there's no difference. Use your intuition. If the differences are meaningful to you, then it raises a red flag. The second aspect we consider is the follow-up. So, was the follow-up duration sufficient? That is, could the event of interest have reasonably occurred during the follow-up period? And was the follow-up complete? If large number of patients are lost to follow-up, the validity of the study is put into question. We don't know the outcomes of these individuals, and they may be different from those who remained in the study. They may be doing really well or really poorly. We need to minimize loss to follow-up. In this study, participants were followed for an average of 2.8 years, and at the study end, 92.5% of the patients were still being followed. So there's a very low proportion unaccounted for, 7.5%. This is quite good. Second, we asked whether patients were analyzed in the groups in which they were randomized. Patients should be analyzed in the arms to which they were attributed by randomization to preserve the value of randomization. This is called doing an intent to treat analysis. If non-compliant patients were excluded from the analysis, or patients who changed arms on their own were analyzed in their new arm, bias would be introduced. This study did follow the intent to treat principle. It's quite likely that patients weren't always compliant. Patients in the metformin arm, for example, might have decided to stop taking the pill, or those in the placebo arm might have made lifestyle changes. That's just the reality of patient care. The third aspect we consider is the outcome. First, we ask whether the patients were all treated equally, except for the component that is under study. Differences in care, other than that which we are evaluating as part of the intervention, can weaken or distort the result. Think of differences in the number of visits or number of tests in the different treatment arm groups. In this study, individuals assigned to the metformin and placebo arm were treated equally, with the exception that one got an active ingredient and the other didn't. But those assigned to the lifestyle intervention did have many more visits. Could that have impacted the outcome? In other words, could the frequency of visits in the lifestyle intervention group have contributed to the outcome? So other than the fact that the intervention was being delivered during those visits, the patients had more opportunities to ask questions, to receive encouragement, to be influenced by other factors. The second aspect of critical appraisal is understanding the study results. What is the effect size? What is the precision of that estimate? What is the confidence of the estimate? How we interpret the effect depends on the type of outcome measured and the analysis done. A separate module is dedicated to that subject, but for now, let's focus on the outcome in this trial. A dichotomous outcome, yes, no. The patient either had the event, diabetes, or not. A dichotomous outcome can be reported in one of two ways: the prevalence, the proportion of cases amongst the eligible population at any point in time, or incidence, the proportion of new cases amongst eligible population within a defined period of time. So prevalence is reported as a proportion and is called a risk, whereas incidence is reported as a number in relation to a time measure, which can either be years or person years. Because of the time component, it's called a rate. To compare two groups with respect to prevalence or incidence, we can report on the difference, the risk difference or the rate difference, by subtracting the measure from the intervention arm from the control arm. Alternatively, we can report on the ratio, so the risk ratio or rate ratio, which is the measure that we obtain from the intervention arm in relation to the measure from the control arm. Finally, we can report on the relative risk or relative rate. And this is derived as the risk or rate difference in relation to the risk or rate in the control arm. Let's work through an example to see the impact that this could have on how we interpret the results. Let's assume one trial is looking at death, the other one's looking at the risk of having a rash. Let's say the risk of death goes from 8% in the control arm to 6% in the intervention arm, and the risk of the rash goes from 40 to 30. To obtain the rate difference, we subtract 6 from 8 to get 2% and 30 from 40 to get 10%. So the rate difference for death is 2% and 10% for rash. In contrast, if we were looking at the relative rate, we would divide the rate difference by the measure in the control arm, and in both cases, the relative rate is 25%. So there's no right or wrong way of reporting things. The reader needs to know what is being reported. This article reports on the incidence of diabetes. So numerator is number of new cases, and the denominator, the measure of time, is the total time all patients were followed. So the person years of follow-up. So this study reported on the absolute rate difference, 3.2% and 6.2% for metformin and lifestyle, as well as the relative rate reduction, which is 31% and 58% for metformin and lifestyle. Are these important differences? Then we ask, how precise is that estimate? The true effect can never be known. We can only estimate the effect. The study provides us with a point estimate. However, it's unlikely to be precisely correct, so we must obtain the confidence interval to determine the range within which the true effect likely lies. A 95% confidence interval is interpreted as a 95% confidence that the true value of what we're attempting to measure lies within that range. If the confidence interval does not include the null value and a ratio that's 1, the effect is known to be statistically significant. So in this study, we can be 95% confident that the true rate reduction for the lifestyle modification will lie between 48 and 66%, while that for metformin will lie between 17 and 43% compared to control. So the last question we ask is whether these results should influence current practice. For that, first we consider whether the profile of the patients included in the study are similar to the patient for whom we wish to apply these results to. Then consider the inclusion and exclusion criteria to determine whether the study could be generalizable to your context. Then we wonder whether they measured all clinically important outcomes, or did they use a surrogate measure because the important clinical outcome wouldn't have been achieved except for 10 years down the road and this was not feasible. So if they had limited their assessment to weight reduction, would that have been sufficient? So in this study, they did measure a clinically important outcome and they reported very clearly. So that's when we consider outcomes, we don't just consider benefits, potential harm or cost or opportunity cost are important to consider. So was there important toxicity? How would that influence your decision? The article should provide sufficient information to allow for decisions to be made based on benefits and harm. Finally, an important parameter to consider is the number needed to treat, which is the estimated number of people that would need to be treated in order to save one case of diabetes. The number needed to treat is derived by dividing 100 by the rate difference. In this study, over a period of 3 years, the estimated number of people who would need to receive treatment in order to prevent one case of diabetes is 6.9. for the lifestyle intervention.
So on behalf of Dr. Dahrouge, as well as the faculty development team at the University of Ottawa Department of Family Medicine, thank you for joining us and taking time to view our presentation. Mark your calendars for our next FactDev Connect webinar on April the 20th. My name is Cynthia Mars, and have a great day.